I would like to introduce Angela Sherman, who it was my pleasure to meet probably 6 or 8 months ago for the first time. What's particularly poignant about Angela's story is that the sort of inspiration behind her setting up the organisation that she now directs was actually the motivation that came as a result of her own parents having a dementia diagnosis, and Angela really quite shocked at the lack of provision there was in terms of funding and the lack of access to continuing healthcare funding for somebody who, as far as we would say, is obviously eligible for it. So I'm sure Angela will explain more about that as she speaks this afternoon, but if I hand over to Angela this afternoon.
Thank you very much for inviting me to speak to you today. I'm Angela Sherman, and the organisation that I run is called Care to be Different. And it's quite an unusual name, but I think there's a lot that needs to be different in care, and particularly care funding. I want to talk to you today about NHS continuing healthcare funding. That's my specific focus. And it's really, as we've heard, it came out of my own experience with 2 parents needing full-time care at the same time, both having advanced dementia at the same time, which was quite challenging, as you can imagine, I'm sure. So I was so horrified at the process that I had to go through to access funding for them, and the things that were thrown in my path, and the obstacles I had to leap over and jump through. But I decided that all of my research over the years that they were both in care, I needed to do something with that, because a lot of other families just don't know about it. So I hope that my talk today will be useful, and there is lots and lots and lots of information on the Care to be Different website. So please feel free to have a look at that. So can I just ask, how many people are aware of continuing healthcare funding? Okay, quite a few of you. Have any of you got it? Not yet. Okay, but some of you have. And are any of you in the middle of the battle to try and get it? Okay. It's not an easy battle, is it? So, have any of you had it taken away? Might be taken away. Okay. It's essentially it's full-time care funding, 100% funding for people with certain needs, and it's provided by the NHS, and it is not means tested. It's healthcare. It's NHS funding. It's not capped. It's not topped up. It's not limited. It's 100% funding for all of the care needs that are assessed, and there's a whole process to go through, which I'll mention. I set up Care to be Different about 4 or 5 years ago, and in that time I've spoken or had email contact with 900 families, most of whom are in despair really at how difficult it can be to access care funding. And it's been really good also to be able to contribute to some of the media coverage about continuing healthcare. Most recently, I was asked to contribute some content for Radio 4's File on the Floor programme. I don't know if any of you caught that. It was a couple of months ago. It was a good programme, quite harrowing, but good to get the issue out there. I'd like to just give you an example of what typically happens when somebody starts to need care. And I know this won't be news to many of you. We'll call her Margaret, and I'm focusing here in this example on an older person. Margaret is at home, and she unfortunately has a stroke, and she's taken into hospital, and she is in hospital for some time, and the hospital then decides actually there's not really much else they can do. She'll have to go into full-time care somewhere. And does she have a house? And does she have any savings? In that case, she'll have to pay for it. Or there could be somebody called Arthur, who perhaps is at home and he has a degree of dementia, and he's getting worse, and his wife decides she can't really deal with it anymore, and he needs perhaps to go into a care home, or he needs extra care but full-time care at home. And the first contact is usually with a social worker, and the social worker may say, well, does Arthur have any savings? Because if he's going to go into care, he'll have to pay for it. And those are two very, very typical examples, and I don't know if you can relate to that kind of scenario. But can I ask, what do you think the biggest myth is about care funding? Anyone care to hazard a guess? You have to sell your house to pay for care. That's a big one, yeah. And yeah, essentially, if you have savings or if you have assets over £23,250, you have to pay for your own care. And it's not necessarily true, but almost everybody is told that. And so very few people are actually told about NHS funding, which has nothing to do with your money. And there's a fundamental principle here that helps explain that. In the UK, and my expertise covers England, there are two types of care. There is social care, and there is healthcare, nursing care. And social care is provided by the local authority. Essentially, they're responsible for social care. Healthcare and nursing care is the responsibility of the NHS. Social care is means tested. NHS care is not means tested, and that's the vital point, because there's a line between the two. And all the talk about integrating health and social care at the moment does not yet affect that line. Social care is means tested, healthcare, nursing care is not. And almost always people are shifted onto that side of that line, onto the social care side, the means tested care, and the other side is never mentioned. And so people automatically start paying for their care. So it's really important to just remember that distinction. So it doesn't matter if you're Richard Branson, if you're J.K. Rowling, if you're Alan Sugar, it doesn't matter how much money you have, it doesn't matter whether you're 9 or whether you're 99. That line still applies, and if, for example, a multi-billionaire needs full-time care and his or her needs are on that side of the line, they won't have to pay a penny. And it's really a key point there. That's the theory. It doesn't always work quite like that in practice. And I suspect there are thousands and thousands of people, certainly in England, paying for their full-time care who shouldn't be. And they are being charged effectively illegal care fees. It doesn't matter what your diagnosis is, it doesn't matter what type of dementia you may have or what other diagnosis you may have, the funding applies regardless of that. One of the biggest problems, I think, is that whenever you read a press article or you listen to an interview on the radio or the telly, and it's about care fees, and we've heard a lot about that lately with the new Care Act, what will be talked about is care fees and care, and just as one whole thing. And what will almost always be mentioned is that, yes, you have to pay for your care if you have money. But what is rarely ever mentioned when I shout at the telly and I shout at the radio is that there's a distinction. It's not all just care. And so that is my main message, and I hope that will help initially just to help you understand the difference between the different types of funding. I mentioned the Care Act, and it's also important to remember that this is effectively a social care act, because it doesn't affect the other side, the NHS, the health care and the nursing care side. Generally speaking, it's a social care act. So whenever you hear about the cap on care fees or things that are changing in means testing, it's all to do with social care, local authority care, means tested care, and not health care or nursing care. I think that the problem that most families have a link with a social worker in the first instance, and this is not to put social workers down, it's just how it is, means that people do tend to get channeled into that side without anybody mentioning anything else. And it's the wrong way around. Because the only way to know if you have to pay for your care is not through an assessment of your money, it's through an assessment of your health and your care needs. And it's only if you're not eligible for full NHS funding that you have to pay. So it's that way around, and usually it works the other way around. People are means tested first, and then they might just happen to find out about NHS funding afterwards. Does that make sense so far? Okay. So NHS continuing healthcare is funding for full-time care for people with a certain level of needs. There is an assessment process to go through. It's quite a long, drawn-out process. Some people find it easier than others to get through. There is still, in my view, a postcode lottery about how easy it is to get hold of. But there are different stages to the assessment process. There is an initial checklist, which is supposed to be quite a low bar, but I'm not entirely sure it is. And it looks at 11 different aspects of health needs, for example, behaviour, cognition, mobility, nutrition, continence, all sorts of things like that. And you're given a score for each one. And the combination of your scores determines whether you go through to the next stage of the process. And the next stage of the process is what's called a multidisciplinary team assessment. And it's a much more involved assessment. It's supposed to pull together all the evidence of your health and care needs and look at the whole picture of need. Again, they look at all of those different aspects of health, and they also look at another one which is just called other. And they look at the nature of your needs, the intensity, the complexity, the unpredictability of your care needs. And they use all of that to decide whether you are eligible. And sadly, and I hope I don't sound too cynical, many people find that the care needs are played down and things are missed out, and the evidence is not always pulled together as it should be. And families play a vital role in making sure that all of the evidence is considered and everything is as it should be. If you are in a period of rapid deterioration or end of life, there is a process called fast track, and that can, as it says on the tin, fast track you for funding. And it's supposed to be immediate, and any argument about it is supposed to take place afterwards. So just keep that in mind. If you are fortunate in securing the funding, then it will cover all of the assessed care needs. If you are in a care home, it covers everything, 100%. You don't have to pay any living costs, it's everything. You don't have to pay any top-up. It doesn't matter, if you're in a moderately expensive care home, it covers all of the fees. I do know people who are in some of the most expensive care homes in the country who are receiving 100% continuing healthcare funding. Not always easy, but it's available. You will be reassessed after 1 year. This is where people can find it really difficult, because not only are you dealing in all of this with the decline of somebody that you love, and all that goes with it, you are then having to battle to keep the funding, or battle to get it in the first place. So you will be reassessed. It should be a full and proper reassessment, not just a quick tick box saying, sorry, but we're taking this away from you now. And then the funding hopefully will continue. If it's taken away, there is an appeal process to go through, which I won't go into because it can be quite a long-winded process, but there is an appeal process. The key thing about eligibility is whether you have what's called a primary health need. And all that really means is that in the full picture of need, the primary reason you need care is because of your health needs and the care needs that result. And in essence, that's it. The primary health need is the key thing. But it's also quite subjective, and some families find that some assessors are more subjective than others in coming up with that decision. You can have continuing healthcare funding whether you are at home or whether you are in a care home or whether you're somewhere else. It doesn't actually matter where you are. You could conceivably be living on a boat or in a tent. If you've got the care that you need and it's safe, then, in theory, there's no reason why you can't have the funding there. There is, and I was talking to somebody about this earlier, there is a key legal case that some of you may have heard of called the Coughlan case. Anybody familiar with that? A few of you. Okay, I'll just explain what it is. It's involved a lady called Pamela Coughlan, who was seriously disabled in a road accident in the 70s. And she received full-time care and she was paid for by the NHS. Then after a period of time, she was moved. And she was told that actually the NHS was no longer going to be responsible for her care, and it was now the local authority, and she would have to therefore be means tested. And she didn't agree, and she took her case with the help of a solicitor to the Court of Appeal in 1999, and she won. And she argued that her care needs were of a level that should attract NHS funding still, and she won and the judge agreed. And that case, it's commonly known as the Coughlan case, has set the bar, and it's a really, really important case because Pamela Coughlan's day-to-day care needs were actually quite low. Although she was disabled, and she needed help with certain things, she's in a wheelchair, she her disability is significant. Cognitively, she's fine. In a lot of other ways, she's fine. She can, employ a solicitor and fight a case to the Court of Appeal. And her needs, in that sense, were actually quite low, but she won. And since then, the NHS have introduced national guidelines, which are effectively eligibility criteria for continuing healthcare. But the eligibility criteria they have set are higher than those of Pamela Coughlan. And so in an assessment process and in an appeal process, one of the key arguments is usually, well, hang on a minute, the Coughlan case says this, and you're saying this. In theory, and I say in theory because it is often a big argument, the law always wins. So any new guidelines that might have been drafted, or practice guidance for assessors, the law wins every time, but it can be a battle to get that point across. So the reason I mentioned the Coughlan case was really to say that the actions of the assessors in denying healthcare funding are often highly questionable because they are denying people funding whose needs are greater than Pamela Coughlan. So I just wanted to highlight that because it's a useful point to be aware of. And the Coughlan case reinforced that divide, that legal limit between social care, means-tested care, and NHS-free healthcare, nursing care. And the judge in the Coughlan case said that, if somebody's needs are more than just incidental or ancillary to the provision of accommodation, then they're on that side of the fence. If they just need a little bit of add-on care occasionally, a little bit of add-on nursing care occasionally, then they might be on the social care side. But if their needs are primarily on that side, they should be fully funded. But you never know if you're going to be successful at securing continuing healthcare. And so, as I'm sure you're fully aware, it's important to plan ahead, think about how things might need to be funded. If you have a good financial advisor, that can be invaluable. But make sure that it's a financial advisor who understands NHS continuing healthcare and care funding and care fees. There is an organisation called SOLA. I don't know if any of you know SOLA. Society of Later Life Advisors. And that is a group of financial advisors who are well versed in care funding and care fees. but it's still worth asking them whether they are familiar with continuing healthcare, because not all of them are as aware as you might hope. So always ask that, always check that. There are lots of measures to try and pay for care and try to avoid having to use up certain assets and money. I'm not a financial advisor, so this is not financial advice, it's just to make you aware. If you have investment bonds, for example, with any element of life cover, then those don't yet need to be taken into account in any means testing. But it's really important to explore this with a professional advisor, because there are things that you may or may not be able to do, and it's good to be aware of that. Generally speaking, it's very hard to hide money from care fees. Also, it's really important, if you're going to pursue a case for continuing healthcare funding on behalf of a relative or on behalf of anyone else, to have power of attorney. And I'm sure many of you have already got that, but it is worth, if you still can, if the person can still set that up and give you power of attorney, it's worth it. Or apply for a deputyship order to allow you to act on their behalf. There are lots of myths about, yes, the question was about two types of power of attorney. One is health and welfare, and one is property and financial affairs. I think it's good to have both. To pursue a battle for care funding, the financial one is fine, but it's always useful to have both. If you're doing it now, it will be a lasting power. If you still have an old enduring power, it's still valid, but it's only financial.
It can be a very expensive investment. I spent £900, and now I've since learned there are cheaper ways to go about getting it.
You can do it yourself, online.
I did it myself. I would say that the comparisons are very useful.
They are, in my view, essential.
I just saying it's very essential. I used to work with them last week.
Yeah, they are really useful documents. I was just saying before that there are lots of myths about continuing healthcare funding. If you are thinking of applying for it, the first thing to do is to contact the continuing healthcare team at the local clinical commissioning group, the local NHS, and ask for a checklist assessment for NHS continuing healthcare. That's the first stage. And one person can do that checklist. It could be a social worker, it could be another health or social care practitioner. And it's really important that you are there when it's done, because otherwise you won't know what's been taken into account or how it's been done. That's the first thing to do, ask for a checklist assessment. But there are lots and lots of...
Sorry, maybe an obvious question, but that would be the clinical commissioning group for my wife's in care, for the area where she's in the home.
Correct, yes, it would be for the area in which the person in care is based. Yeah. When you ask for a checklist, there are lots of things that you might be told. And I don't know if any of you who've been through this process can suggest some that you might be told that are not quite true. One of them is, oh, it's not worth it, you won't get it. I've heard that so many times. Yes, you will be put off and told that you're unlikely to be successful, or you could even be speaking to somebody within health and social care who's never heard of it, and you will have to explain to them what continuing healthcare is. And it's really disheartening.
Can I make a point about this checklist?
Mm-hmm.
I've had a look at it, and with a view to imagine that I'm the person setting it up to see if my wife should get it. And obviously it's in my interest that we do get it. And when I went through, I thought, it's going to be years before my wife is degenerate enough for me to be able to fill in this form in a way that the National Health Service would want it filled in, because after all, they are trying to save expensive money. And I just think that we ought to have a go at looking at the form ourselves and imagining where the society is coming from when we see whether we could fit it in.
Yes, the bar is, in my view as well, quite high, but just because the checklist eligibility criteria, they're not really eligibility criteria, it just gets you through to the next stage, just because those are set in the way they are, it can still be worth having it done because it sets a benchmark. So, for example, if in 6 months' time there had been a deterioration and you wanted it to be done again, the first one and the second one would show that deterioration. So even if you don't think you will get through to that next stage, it can still be worth having it done. Does that make sense?
Yes, it does.
Yes, I was going to make a comment because for more than 10 years now I've been challenging and doing these cases for people through the FDD group. It is a national guidelines, they're national questions. I have copies of them. When people want assistance, I always send it to them, together with the guidelines, which is what the professionals have. And if they send you the form, they often don't send you the guidelines. So you can read what they're being told to do. And also, it's important that you evaluate the patient the worse they are on the worst day. This is not a moral statement that we're making about people. This is people with disease, the body is performing in that way, and a lot of people don't like saying how the person is actually behaving now. It is important, without lying and with having some evidence, that is what is captured. And in going into these meetings or in challenging this, as I say, I always get the patient, the family's view, and that's what we then use to go and challenge these. And admittedly, you do have to be in a given state, but it might not be the state that you're assuming. I don't think we've lost the case yet. And that's up and down the country. Just had one going on in Nottingham. So it's up and down the country, and it's always been done for free as part of the support group. One last thing I thought you might just like to comment on, looking at the audience, is when they're evaluating funds and money, what it is when they are married. And for example, there'll be the joint house, but there are ways of not forcing people out of their own property just because the patient's name is on the deeds and so on.
If I could just come back on that particular point, remember that's on the social care side of things. Anything to do with property, how it's divided, how your money is, joint money, separate money, is all to do with social care. And continuing health care is all to do with NHS funding. And so the money, the house, the assets, savings don't come into it at all, just to keep that clear.
So we'll carry on with Angela's presentation and then have questions at the end.
Sure, thank you. So just going back to the point where you ask for a checklist, you may well be told it's not worth it, don't bother. You may have to explain to the person what it actually is. You may be told a number of other things that are not true. You may be told it's only for end of life. Not true. Many, many, many people are also staggeringly told it's not for people with dementia. And that is so not the case. It doesn't matter what your diagnosis is. And I find it incredibly sad that people are told that by people working in health and social care. Some people are told you have to be in a coma. Not true. Others are told you have to be peg-fed. Not true. So many people are told incorrect things, and I, at the risk of sounding cynical, I do think it's either a serious lack of training or an attempt to put you off. So be vigilant. Some other people are told, the person has to be kicking and screaming the whole time, and again, that's not true. It's a whole picture of need, regardless of diagnosis and regardless of any one individual trait. So be vigilant and don't believe anybody that says, it's not worth it, you won't get it, or anybody that says you always have to pay for your care, because again, that's not true. If I just quickly relate that back to my parents, they both went into full-time care, into a care home at the same time on the very same day, both with dementia, and I, at the time, knew absolutely nothing about this. And I assumed, because I'd been told by the social worker that they had a house, they'd have to sell it, they'd have to use up everything and pay for their care. And for 2 people in full-time nursing care, it was a pretty hefty bill. And it was only by chance that I happened to see a Panorama programme about the Cochrane case. And it went from there, and it eventually took me about 4 years to fight the battle to get them fully funded. And they were fully funded right up through end-stage dementia, right up until they died. And through that time, the reason I mentioned the 4 years is not to put you off doing it, because it may not take that long. And I had 2. So it's just to say that through that time, the number of things I was told that were incorrect and that were, I believe, designed to sort of undermine me were quite staggering. And so just be aware that when you do challenge it, sometimes they'll back down. And so you need a certain level of stamina and energy and persistence, but it certainly can be worth it. Be also quite vigilant about the type of language that is used in assessment notes. If I relate that once quickly to my mother, she was effectively paralysed. She had several strokes, she had advanced Parkinson's, she had severe dementia and all sorts of things. She was immobile and she was moved from A to B in a wheelchair. And the assessment notes said she uses a wheelchair for distance, which I thought was interesting, as if she was going to take part in the next Olympics. And it's that kind of really subtle language that you have to be really careful of. I've seen assessment notes for people with advanced dementia that say they're just a bit depressed. And it's absolutely shocking and very, very sad, but it's just really important to be aware of it. So, Care to be Different can offer you lots of information on NHS continuing healthcare. If you go to the website, caretobedifferent.co.uk, and you have a look at the homepage, you'll see a link on the homepage to vital information about care funding and NHS continuing healthcare. And if you click that link, it takes you to a very, very, very long page, but it will, I guarantee you, probably answer most of your initial questions. So it's worth having a look at that. If you do need further help, then we can put you in touch with someone who can help. But there's lots of information you can access for free. You can also sign up for a regular news bulletin, which is always full of useful, I hope, useful information. And you can download a free initial guide to care funding from that. So that's really what I wanted to say. I hope that's been useful in some ways. It's a very quick overview, but I hope it's perhaps helped you be aware of what is available. And always remember that line: anything to do with the Care Act, anything to do with means testing, houses, assets, savings, is on the social care side of things. Anything to do with healthcare and nursing care is not means tested. So thank you for listening, and I'm happy to take further questions.
Hello Angela, thank you very much. Can you tell whether the person needs to be in a care home or a nursing home? Because near me there are some really nice nursing homes, but I've seen a care home which I feel is more appropriate. I've looked at lots that were recommended, and they all are set out very much for people with Alzheimer's, with lots of signage and things that they can follow. My husband can't follow that. But the only one that I've seen really suiting is a care home.
Okay. In terms of the funding, it doesn't matter. It can be a residential care home, it can be a nursing care home, it can be at home. The type of place is irrelevant.
Right, because that ties up then with the fact that nursing care doesn't have to be provided by a qualified nurse. it can tie in with what I'm doing day by day.
Yes, that's a really good point actually. It doesn't matter who delivers the care. It could be yourself, it could be a registered nurse, it could be somebody else. I don't know if any of you have come across the Poynton case. You may remember it if I talk about what it involved. It was a lady called Barbara Poynton whose husband Malcolm had severe dementia, and she cared for him at home, and she needed some help. And she argued that the care she provided was of no less value than the care that anyone else would provide, because it was the same care. And she succeeded in receiving NHS funding. I think hers was for respite. But yeah, it doesn't matter.
That's great, because that's one of the things I was told was, well, if it's not a nursing home, you won't qualify.
That's very common. It doesn't matter at all.
And I just say to everybody, keep notes. Whatever you're doing, keep a diary of things getting worse, things changing. And the thing that Jill had sent out to everybody, examples and risks. Not just this person can't feed themselves. Well, what are the risks of them not feeding themselves? What are the risks of them not being able to cross the road? The risks of them not being able to wash themselves or understand things. And we forget those risks because they're the things that could lead to really rapid deterioration in health or death.
Yes, you're right. And in the assessment process, the assessors are supposed to look at risk assessments, whether it's moving and handling, nutritional risk, risk of skin breakdown from pressure sores or whatever. You're right, the risk is really important. And there are lots and lots of risks that you can identify from the various different aspects of health. And that is really important. And keep notes. Keep a diary if you can. And another really important thing is, in any assessment process, and certainly in any appeal, the assessors or the reviewers will look at the daily care notes kept by either the care provider or perhaps by yourselves. And those care notes are fundamental to the process. And very often people find that they're not, if it's been kept by somebody else, that they're not actually adequate because they don't really detail what's needed for a funding assessment. So keep as much information as you can, even if it feels really pedantic or wearing or draining to have to keep writing it all down. It is really important.
I just wanted to ask, what would your general advice be about whether someone should appeal against a decision, or whether they should perhaps wait for a little bit longer and then make a fresh application? The reason I'm asking that is that I'm involved in trying to help support someone who did get turned down, for the most peculiar reasons. And I encourage her make notes in the way that you've described, and she's finding that very difficult. This is actually about her husband. But I feel that she would stand a much better chance about making a fresh application with the evidence to support what she's trying to say. Because one of the things that came through with the assessor was she couldn't seem to quite understand the fact that the man in question, the resident in the nursing home, he does have very severe health needs, but because they were being met, because it's quite a good nursing home, she just was dismissing that, which wasn't helpful. And I think that's another important point, really.
It is. There's 2 points there, actually. One is that if you are going to appeal, the benefit of continuing to appeal is that when you eventually win, it will be backdated back to the checklist. If you start a fresh process and then you win, it will only be backdated to then. So, pros and cons, and it depends how much energy you've got. But the other point, very good point, was about managed needs. And in all of the guidance, it's very, very clear that just because a need is being managed doesn't make it any less of a need. And a lot of people find in assessments that the assessors will say, well, the needs are all being managed perfectly okay, care seems to be pretty routine, no funding. And it's a fundamental flaw, because all of the guidance says that needs should not be marginalised just because they're being well managed, because the management of those needs needs funding. So don't be fooled by that one, just in case you come up against it. This gentleman has had his hand up for ages.
I hope this works. 2 or 3 points. Firstly, the recent government legislation on carers is a totally different scenario to that existed before. It's managed by the local county council through their social services, and there is no means test. They don't need to assess how much money you've got. They need to assess how much care you need, and therefore they will fund that care with a one-off payment. And you can, in fact, employ your own carer on that sort of funding, if you so wish. I went to a lecture on it recently, and the local county council social services have got quite a big plush booklet answering an awful lot of these questions. They are not looking at it from the side of whether you need long-term care and going into a nursing home, and I think that is where they differentiate between what the NHS do and what the social services do. But underlying that, of course, there's also the opportunity for anybody who is caring for somebody to get a very basic carer's allowance from the pensions department, which is about £50 a week.
Okay, thank you for that. Thank you. That's. Do you know what the booklet was called that you mentioned?
No, I don't.
Okay.
I've got one. It's a link forward.
Okay.
I'm probably going over old ground, but my husband's gone into respite and he's in there now permanently, and I've just applied for continued care. And through the National Hospital that my husband was under, it was also said to me that because he's now in a home, it's probably less likely that I'll get it if the care in the home is coping with him. And he can't talk, he's now being fed, and he's slightly unsteady on his feet and is doubly incontinent. And I've gone through the checklist with someone that was supporting continued care staff because they were overloaded. I don't think he'd ever done continued care before, but he was the one that actually made the decision at the end of it to say that if I wouldn't qualify. Then it went to panel, and obviously I've got the forms back to say that we didn't qualify, which I will appeal. So I feel that on that filling in the form, I put everything down. I could possibly think of, I thought of all the risks. I had Jill to help me with all the things I should think of. And I think it was the home's assessment, which they had agency staff come in sometimes, and I think it's the home assessment. They're not understanding any of this, and they're putting in all the positive sides of it, of my husband, rather than the negative sides, making it sound like a lovely home, and yes, we can do this and we can do that. And he is very obliging because he has to be directed all the time, can't make any decisions himself. And he's a very good patient, he doesn't shout out or scream or anything, so yes, he's easy to handle. So that's no reason, because there are risks involved. And I just feel that I've been under with the care home's assessment, which has caused me not to get continued care. And also, I mean, what the other thing I was asked is what would make it not possible for him to get continued care? What would be the criteria not to qualify? I don't understand.
Two points. The point you made about the care home is it's such a common thing, and it's so frustrating because carers who are filling in care notes who don't really know the person being cared for, and who don't understand what those care notes are going to be used for. It's a major problem that I think really does need addressing. So I can totally understand that that's happened, and in your appeal, if you go through to an appeal, that would be one of the key points to make, is that the care notes are inadequate. And it's a very common reason for appeal. Yeah, so that's one of the difficulties, because you're kind of battling with the people who are looking after him, and it can be really tricky. And a care home will naturally want to show that they're providing good care. And so they would say, it's no problem, you know, we can care for him fine, it's no problem, this is okay, every day's fine, he's happy, I mean, ridiculous stuff, but And it is a big problem, and it comes down to challenging that.
I did say to him that if he was at home, I wouldn't be coping because he can't do this, he can't do that. But because he's in a home and he's on the flat, there's no danger to him, there's less risk. So therefore, being in a home, I was told that possibly that would all go against you because they're coping, but you couldn't cope at home. So when I did fill in the checklist, I said to him, I hope the home's not going to make it look better than it is, because you've got to assess it on how it is at home. The reason why it's not at home now is because I couldn't cope.
Yes, and it comes back to the managed needs thing, and as part of that, what's supposed to be assessed are the underlying needs, the reasons why somebody needs care in the first place. And I've been, it's nearly at an end now, but I've been helping a client through that very same argument, where her mother was violent, and when she went into a care home, she was much calmer because they were able to kind of manage that behaviour. But she's appealing on the grounds that the underlying need was what happened before she went in, and I think that would probably have to be the same.
Hello. What I don't understand is, you said people get assessed, if they're lucky, they get continuing health care, and then after a year, then they can get it taken away. Now, if we're talking about conditions like dementia, which are deteriorating conditions, how on earth can it be judged that it's right to take it away? And I think that is, when you think what you've gone through to get it, people to have had it for a year and then it pulled away, that seems to me terrible.
Yes, it's cruel. What the argument is that someone's needs will change. For example, somebody with perhaps very challenging behaviour may subside and they may become much easier, in inverted commas, to care for. If it's that particular example, then the assessors may think, well, actually, the reason that the thing that tipped the balance into funding last time is no longer relevant. But my view is that there are almost always other needs that have arisen. For example, if somebody has been quite mobile and dangerous because of that, and at risk of falls, then they may have got the funding, that may have upped the score and they've got the funding because of that. When they then become immobile, there is a tendency for, in some cases, the decision to be, well, they're not at risk of falling anymore, therefore, the needs have gone down, no funding. But if somebody becomes immobile, there are other needs and there are other risks. Skin breakdown, contracture of muscles, all sorts of things. And when that happens, if you are reassessed and there is talk of taking away the funding, it's vital to push up as much as you can all the other needs and risks that have arisen. But it's cruel.
Okay, so we've got a question here from someone listening in online who says, Dad's care home funding is currently being funded by a body called IBC, which is in Northamptonshire, and apparently that's because he's under 65. This is a 50-50 split between social care and NHS healthcare. It's all currently means tested. Should the 50% funded by the health pot not be means tested, or is it just when they fund 100% of it?
That's an interesting question. I would have said it should not be means tested. I don't know, Lynn, if you've got a view on that. But if it's from the NHS, it should not be means tested.
And when one is looking at the highest levels of NHS funded care, then key things are what involvement of a doctor is involved. So somebody can be really seriously ill but stable and therefore easier to manage than someone who constantly needs the intervention of a doctor. That would make it higher. Also, people who with a lot of aggression that themselves, their behaviour is not stable. We can argue whether we think this is right or wrong, but if you look at how the assessments are made, there are issues like this that make it higher into the health rather than social services. But there is also, or the point I was going to make is it's not either or. You do get mixtures as people go through. I'd be surprised that a nursing care element was assessed for means, but certainly the social side always will be. And that's why I was making the point before that it is important to realise that you're unlikely to get thrown out of your house because today your partner is getting social care and it won't all be labelled as hers. One has to be careful. But I've presented to many, many nursing homes, and the key message always is, we are now, yes, Daddy is lovely. I said this to my children. Daddy is lovely, we still love Daddy, but now we're living with a disease. And we have to separate the disease from the person. And as I said before, we are not making moral judgments, we are documenting how this body is currently performing. And if it's not on paper, then it didn't exist. And in the Court of Protection recently, this nursing home, the clinical director said, oh, we couldn't cope with him yesterday. He was in a terrible state. And I'd asked to see his notes, and I said to the clinical director, well, where's this documented then? Where's any of his behaviour documented? And it is a much, much more difficult case to argue when it's not on paper. It needs to be on paper. And of course it wasn't on paper because the clinical director was moaning, but he didn't want me to move this patient from his home to another home that could cope with him.
Thanks, Lynn. Just a quick point on something you said, stable needs. Very often an assessor will say, well, their needs are stable, therefore they're not eligible to be funded, and that again is a misleading thing. It's the whole picture of need.
Oh, hi, I'm just thinking about to shed some light on our situation. My mum was admitted to hospital with a mental health act. And so under section 117, we're entitled to some support. I don't know whether that process, I think we're dealing with the local authority, but they are talking about supporting us with fees when she will have to go to home. Okay. But I'm really not sure, we're getting really difficult to advise about whether we can have a top up or not. I don't know what the rules are.
If she's under a section, then her care will be paid for, whoever it's funded by. If that section is removed, she will then need to go through the assessment process.
And can you top up yourself? That's what we're really confused about.
If she's funded under a section.
Because they're trying to show us homes that are not suitable.
Okay. If they're not, I would take it on a different angle actually. If they're not suitable homes, then the issue there is that she's not safe. And there may potentially at some point be a safeguarding issue. But the funding for people under a section and the funding for continuing health care is different. But if the section is then lifted, she will need to be assessed for continuing health care. Does that help?
Thank you, Angela. I'm sure we could keep you here all afternoon, but thank you very much.